you so much for being here with us, and I apologize for being a little bit late. I was giving a last talk in the other session, and they won't let me out. So, but I'm glad that we are here. I'm also really glad to have my co-moderators here, Dr. Phil Newsome from Roger Williams Institute in London, who is an expert in liver disease and also brought GLP-1 receptor agonists to the forefront in the treatment of steatohepatitis, and Dr. Manal Abdelmalek, professor of medicine at Mayo Clinic, who's been involved in clinical trials in NASH across a multiple spectrum of therapeutic landscape. So today we're going to be, getting into a deep dive into steatohepatitis and its therapies. These are some of the things about the live event. Use your own technology, and you can take this. This is the Wi-Fi code, and you can scan the QR code for the Q&As that we'll be doing during the session. And this is, if you wanted to join through your personal device, you can. New Horizons in MASH Management. So I'll kickstart this CME symposium, which is developed by Medscape Live, and this is my faculty that I recently just introduced. So this is going to be the timeline of our program today. We'll start with overview and pathophysiology, followed by incretin-based therapies by the expert in this area, Dr. Newsome, PPAR agonist by Dr. Abdelmalek. Then I'll discuss FGF21 analogs, followed by thyroid hormone beta receptors agonist by Dr. Abdelmalek. And then we'll have a Q&A session and take all your questions at the time. So this is the new nomenclature. I think you've seen this slide. In totality, we now, in 2025, take all patients who have presence of steatosis on their imaging modalities, classify them as steatotic liver disease. In steatotic liver disease, most common cause remains MASLD, which is metabolic dysfunction associated steatotic liver disease, which previously used to be called NAFLD. Within that, we have two broad categories. One, the milder form called metabolic dysfunction associated steatotic liver, where there is no injury, but you have fat in the liver. And then there are patients who have metabolic dysfunction associated steatohepatitis. This is the progressive form of MASLD that can lead to fibrotic disease, cirrhosis, and future development for liver cancer and liver-related morbidity and mortality. We also note that patients who drink excessively also have fat in the liver, and that's alcohol-associated liver disease. Recently, we've also recognized an entity that you all have previously seen in your clinic. There's an individual who have metabolic risk factors, but also drink excessively, but not to the extent to be classified as alcohol-associated liver disease. And these are individuals who may consume somewhere between more than 2 to 3 drinks per day to up to 5 to 6 drinks per day. And that, along with a metabolic risk factor such as overweight, obesity, type 2 diabetes, dyslipidemia, hypertension, and those individuals are now classified as MET-ALD. There are other causes that are also very specific associated with steatotic liver disease, such as drug-induced liver injury, monogenic diseases, and also cryptogenic steatotic liver disease that could be seen when you're not able to associate any of these findings with that. And potentially there might be genetic underpinnings that we might recognize in the next few years in that particular category. Now, if we look at patients who are normal, as they gain weight, they could develop hepatic steatosis. And then as they develop insulin resistance and accumulate multiple metabolic risk factors, they may go on to develop MASH, which may lead to fibrotic disease. And then over decades, they may progress to cirrhosis. Some patients with MASH may develop hepatocellular carcinoma without going through cirrhosis, although typically we see hepatocellular carcinoma in the setting of cirrhosis. There are certain genetic risk factors that increase the risk for MASLD progression, such as PNPLA3, TM6SF2. Of course, diet plays an important role. We are recognizing that gut microbiome may be playing an important role. Particularly if you think about metabolic risk factor, type 2 diabetes and obesity are two critical risk factors. Patients who have type 2 diabetes, 50% of them may have MASH. 70 to 80% of them have MASLD. Similarly, in the setting of obesity, we are seeing higher rates of advanced fibrosis. So those are two entities where we should be thinking about screening for MASLD and advanced fibrosis. Now we're going to look at this animation that we've developed where you will see some of these important pathogenetic mechanisms.
The central defect in the pathogenesis of steatotic liver disease, particularly metabolic dysfunction-associated steatotic liver disease or MASLD, is presence of hepatic insulin resistance. Majority of our patients are overweight, obese, or may have type 2 diabetes. In the setting of overweight, obesity, and type 2 diabetes, we start seeing elevated levels of insulin. This hyperinsulinemia has impact both on the peripheral adipose tissue, and this leads to increased trafficking of free fatty acids coming from peripheral adipose tissue into the liver. Inside the liver, elevated insulin levels or hyperinsulinemia leads to activation of SRBP1C, and this activation leads to increase in lipogenesis. In patients with increased hepatic insulin resistance, what we start noticing is that they start storing this triglyceride in the liver in the form of liver fat inside the hepatocyte. And we also notice perturbation and mitochondrial dysfunction as this injury continues. Increased glucose level is also associated with activation of ChREBP. This leads to inhibition of AMP kinase and downstream regulators, which further leads to increased lipogenesis and de novo lipogenesis. We also notice that patients with steatohepatitis have gut dysbiosis. This gut dysbiosis is also associated with progressive liver disease, where we start seeing activation of quiescent hepatic stellate cells by recruitment of Kupffer cells in the liver. Activated hepatic stellate cells lead to deposition of collagen, leading to fibrogenesis. If this process of injury continues unabated with continued weight gain, worsening insulin resistance, and lipotoxicity, patients go on to develop progressive liver disease, fibrosis, and cirrhosis.
Now that we've understood some of the key issues related with MASLD, progression to NASH, and fibrosis, we want to think about several of these pathways in this construct. So if insulin resistance and lipid metabolism is important, then we start thinking about lipotoxicity and oxidative stress as a major driver of liver disease or progressive MASH that's causing injury in the liver, leading to fibrogenesis. This increased fibrogenesis in certain patients with increased genetic susceptibility may lead to cirrhosis in some of our patients with MASLD. Now, if you think about therapies related to MASH, for FDA regulatory framework, we are looking at two important endpoints. One is MASH resolution without worsening of fibrosis, or fibrosis improvement by at least one stage without worsening of MASH. These are the two important intermediate steps that we look at on histology for reversal to think about whether a therapy should be used in clinic. Now, we're also interested in long-term clinical outcomes, which include progression to cirrhosis, decreased risk for hepatic decompensation, or liver-related mortality, or reaching a MELD score of 15 or higher. This is the construct for judging whether the therapy is deemed safe and effective in the setting of our clinic. This is the historical and current pipeline of steatohepatitis. And over the next 25 hours, we'll discuss each of these. I'm just kidding. This is just giving you an idea that this disease is really an active area of investigation, and we're looking at multiple therapies. Today, we will discuss specific therapies that are in late stages of development. So you're aware of them because their likelihood of coming to clinic is higher in the next few years. Again, a whiteboard evaluation and assessment to give you an idea as to what we are thinking about and how these therapies may be working in various pathogenetic mechanisms.
Here we are discussing drugs in development for MASH target of number of different pathophysiological processes, including metabolic dysfunction, inflammation, ballooning, and fibrosis. Under metabolic dysfunction, we have derangements in fatty acid metabolism, insulin resistance, and bile acid synthesis. Drugs in development or approved for MASH that target these pathogenic processes include PPAR gamma agonist, thyroid hormone receptor beta agonist, GLP-1 and GIP agonists, SGLT2 inhibitors, and FGF21 agonists. We also have pan-PPAR agonists that are also important in the pathogenesis of steatohepatitis and fibrosis related to steatohepatitis. Several drug classes also target fibrosis in both early and late stages of development, and these include pan-PPARs, GLP-1 analogs, and FGF21 analogs. This is not a complete or exhaustive list of all the drug targets, and others are still being researched. In terms of clinical outcomes, the FDA focuses on two main endpoints for MASH drugs in clinical development. Resolution of MASH without worsening of fibrosis as one key endpoint, and the other endpoint is improvement in one stage of fibrosis without worsening of MASH. Other clinical studies of emerging agents are focusing on later stages of disease, particularly in the setting of cirrhosis. Now, we are aiming for reversing fibrosis and halting disease progression to cirrhosis in these patients who have NASH stage 2 or 3 fibrosis. But there's also clinical drug development for reversal of cirrhosis, but also prevention of decompensation and liver-related morbidity and mortality. We eagerly anticipate results from these studies.
Now we're going to look at a question, so if you could scan this with your devices. Which of the following agents under investigation for MASH with stage 2 and stage 3 fibrosis is a pan-PPAR agonist targeting PPAR alpha, delta, and PPAR gamma? Number 1, efruxifermin. Number 2, pemvidutide. Number 3, lanifibranor. Number 4, seladelpar. Okay, great, excellent. So you all did very well. 55% responded with lanifibranor. Well, this would be a good exercise because we're going to get the other 45% also to respond correctly as we move forward. Thank you for your responses. These are some of the agents that are in phase 3 clinical trial development for MASH stage 2 or 3 fibrosis without cirrhosis. If you look at the top two, those have conditional approval based upon the histologic endpoints, but those studies are still continuing for long-term clinical outcome. One is resmetirom, which is an oral thyroid hormone beta receptor agonist, and then semaglutide, a GLP-1 analog. Then these are the other compounds that are in clinical development in phase 3, and we'll discuss some of them. Lanifibranor, as you can see, is an oral pan-PPAR agonist, and the phase 3 program is ongoing and fully recruited. Now we will move on to incretin-based therapies, and I'll invite my colleague, Dr. Phil Newsome, to discuss that.
Brilliant. Thank you very much, Rohit. And I think when it comes to incretin-based therapies, I think what's really exciting is just how much work there's been in the field and how some of these therapies, as you've heard, one is already approved in the US and the others are hopefully not far behind. I think the other dimension with these therapies, which is important, is that we know that we're seeing efficacy in the trials in the liver setting, but also we're seeing a sort of broader set of benefits that affect people with this condition. So with that, then, I would ask you to scan the QR code, please, and if you could please answer in that 1 to 5 scale. So overall, on a scale of 1 to 5, what do you think is the clinical value of incretin therapy in adults with MASH, F2 to F3? And it goes 1, very important, 2, important, 3, somewhat important, 4, slightly important, and 5, not important at all. Good, excellent. So there's 2% in the room that think not important and 2 slightly important. So I may be slightly influenced that decision. But anyway, so the thing about incretins, think of them as a sort of cluster of different hormones, often gut-derived. And often what happens when we think about therapies, they are modifications of these hormones to make them longer acting, because the body is a finely calibrated system, and often these hormones break down very quickly, so they're often modified to give you a longer action. So there are 3 that I'm going to touch on today. The first one is the one that Rohit alluded to, which is glucagon-like peptide 1 receptor agonists. And they are known to have some key effects. One is we know that they act in the brain to suppress appetite. We'd also know that they slow down gastric emptying. We also know, and this is one of their indications, we also know that they improve insulin sensitivity and are therefore used in people that have type 2 diabetes. I'll say more about that in due course. The other hormones, you've got glucagon. And again, glucagon obviously normally counteracts the effects of insulin. Where it's particularly relevant in this setting is that we know increasingly that patients, people with MASH, have got a form of glucagon resistance or glucagon dysfunction. So that when you treat liver cells or fat tissue with glucagon, you don't get the sort of normal response you'd expect to see. And therefore, the theory behind glucagon is that it will, overcome some of those problems and then drive some of the beneficial effects which are illustrated on this slide and which I'll touch on in subsequent slides. And then the final hormone, GIP, again, is a really interesting hormone, which we know, again, in the context of MASH, we see that the receptors that it binds to are slightly desensitized or downregulated, and that therefore this administration of this hormone sort of almost returns the sort of function of the receptor back to normal. And we know that it works with GLP-1 to sensitize the effects on appetite, and we also know it returns some of the function in adipose tissue. So these are sort of illustrated on here, but what I'll do is I'll walk through some of these over the next few slides. So this is one example, which is where you combine GLP-1 with glucagon. So you sort of get the best of both worlds. You get the effects that you see with the GLP-1, which are indicated on the right, but you also get a sort of liver-targeted effect with the glucagon, where you start to see this effect on breaking down more of the fatty acids through increasing mitochondrial function and beta oxidation, but also you start to see improvements in terms of reducing de novo lipogenesis. So again, think of it as a sort of liver-directed incretin. And these are some of the other combinations. So on the left, you have tirzepatide, which is the combination of GLP-1 with GIP. And on the right, you've got the triple combination where you've got all 3 hormones. So again, I'll touch on tirzepatide in further slides, but you see this augmented effect on weight loss, as well as this sort of improvement in fat tissue dysfunction. And on the right, by adding in the glucagon, you're also getting that additional dimension on beta oxidation and weight. So let's look at some of the data. And Rohit alluded to this at the beginning. So this is an ongoing phase 3 clinical trial, the semaglutide trial in people with MASH. It's a trial which, like most of the phase 3s, has sort of 2 endpoints. It has the interim endpoint, which is looking at histological efficacy, and then the longer-term endpoint, which is looking at these hard clinical endpoints. So it's randomized 2-to-1 in favor of semaglutide, so people receive this once weekly. It's an injection of 2.4 milligrams. And the data which I'll touch on and which led to the decision, based on that 72-week analysis where you're looking at the change in liver biopsy findings. And these are illustrated here. So there are 2 primary endpoints that we look at. The first is resolution of steatohepatitis with no worsening in fibrosis. And what you see in the blue bars with semaglutide is that people receiving this had a substantial difference and improvement over the participants receiving placebo. So there's almost a 30% increase in response. And then similarly, and this was important because this was a change from the phase 2 clinical trial, is also demonstrating an improvement in liver fibrosis after 72 weeks. So you can see there just under 37% of people on semaglutide had an improvement in fibrosis with no worsening in MASH, as opposed to 22% on placebo. Again, you'll be familiar with side effects around GLP-1 receptor agonists. We know that they can cause nausea and vomiting. We know also that that is something that you can attenuate if you up-titrate slowly. So in this study, patients are up-titrated sort of every 4 weeks. And we know that after people get over that bump, often there's a reduction in those side effects. But of course, for some people, they do continue, but for many, they settle. As you can see in terms of the more serious adverse events, the fatal adverse events and the serious adverse events, there was a reduction, if anything, in patients taking semaglutide. So this obviously culminated in the accelerated approval by the FDA, specifically for adults with MASH and F2 and F3 fibrosis. This is sort of being woven into some of the updated guidelines. The treatment, as you can see there, it starts off with a 0.25 milligram subcutaneous injection once weekly for 4 weeks, and then there's this sort of gradual dose escalation, which we know is important in reducing the side effects. And there are some important contraindications and drug interactions there on the bottom, which I won't read out, but which you'll be familiar with and can look at later. So I talked about GLP-1 alone. What about the combinations? So this is the combination of GLP-1 and glucagon. So you're getting that sort of liver incretin effect. This is a 4-arm study, so 3 different dose arms, as you see often in a phase 2b clinical trial, 3 different dose arms of survodutide and 1 of placebo. The up-titration was a little quicker in this study, every 2 weeks. And again, as with most of these studies, it's the histological evaluation at 48 weeks. And again, what you see here these are the data looking at improvements in inflammatory injury. The endpoint here was slightly different. It was a reduction in the NAFLD activity score of 2 points, of which at least 1 needed to be in lobular inflammation or ballooning. And again, what you see here is a clear description or a clear depiction of that increase in the rates of clearing steatohepatitis, clearing that inflammatory injury in people receiving this, 14% in the placebo, and then the 3 different dose arms there. I talked about the up-titration. You can see the side effects on the right-hand side. I think this probably reflects perhaps a slightly rapid up-titration, which has been changed in the phase 3 clinical trial. And then tirzepatide. So this is, again, the phase 2 clinical trial. So this is looking at the combination of GLP-1 and GIP. Again, it's a large phase 2 trial, just under 200 participants. Again, they had to have, as with all of these studies, stage 2 and stage 3 fibrosis. So again, what you see here is 3 dose arms and a placebo with a liver biopsy at 52 weeks. And the primary endpoint, again, very much in keeping with these types of trials, indicated on the right-hand side. So there's a bit on this slide here. On the left-hand side, you have that characteristic improvements in resolution of steatohepatitis. So you see, we're now starting to see really quite big jumps in resolution of steatohepatitis here. So 10% in the placebo, and then you're going up to 44, 56, and up to 62% at the highest dose. So really big changes in reductions in inflammatory injury. But what about fibrosis? Again, if you look on the right-hand side, again, you can see statistical improvements in that. One of the things that we notice is that the placebo response arms really vary quite a lot across the trials, which is one of the reasons why we need to have them. But you can see this delta there of sort of 20+% in the 3 active dose arms. Side effects, again, reported, lots of sort of GI side effects are found in the incretin therapies. But again, up-titration is how to manage that. And I think we're getting better as a community in terms of how we speak to people and patients that are on these treatments so they can get over those barriers. So that's really a kind of synopsis, a really exciting time for these treatments. So I think now we're going to have a little discussion, Rohit, aren't we, on how we use them or how we might use them in the future.
Yeah, so how do you think that we might be thinking about that we have now 2 therapies, we have resmetirom that's FDA approved, although conditionally, and now semaglutide. Would you consider combining them, or would you consider, using them, one first and then the other one followed by that? What are your thoughts on that, Phil?
Yeah, no, sure. So it's a really good question. So, the US is the only place where these 2 therapies are approved. So it's a specific question for here at the moment. I think that inevitably, we are going to have many more patients taking incretin therapies for other medical reasons. And what we see in many of the trials now is patients are entering trials already on an incretin. So I suspect there will be a higher baseline use of incretins, and I think they will be very helpful. They will probably move the bell curve over. But there will be patients that either don't respond or don't tolerate them. And for those individuals, you can certainly see the need for additional therapies. And I think resmetirom is a very good example of that. There'll be other people that don't want to inject, don't want to take those therapies. And again, we can see data with resmetirom, which demonstrates, or we're going to see it in due course. I think one of the things we probably need to understand as a community is the difference between a combination treatment to start with and how we add on therapies to people that haven't perhaps had a response, because that's a slightly more difficult to treat group.
Yeah, no, certainly. Manal, your thoughts on this, before we look at what's on the other side of this slide?
Yeah, no, I couldn't agree with Phil more. When I evaluate a patient, I really kind of try to size them up, if you will, with regards to their metabolic risk. And if I'm seeing a patient who's obese and diabetic and their hemoglobin A1C is 9.5, for example, my priority is really to control their metabolic drivers first to decrease the risk for cardiovascular outcomes and diabetes. And so I may start a GLP-1 as a first-line therapy and consider an add-on resmetirom, particularly if their fibrosis stage 3, and may not take necessarily that approach if I was dealing with a lean individual who's not obese, not diabetic, in which case then maybe resmetirom, maybe my first-line therapy. I think the beauty of this is we have the opportunity now to personalize care, individualize care as we address these metabolic risk factors.
That's a great point. With that, if you look at the therapies that we listed in phase 3 development currently, one of the therapies that is there is lanifibranor, and that's an oral treatment that I think majority of the others that we're looking at in the pipeline are injectables, such as semaglutide. Phil, based upon the totality of evidence that you've seen, are all patients able to tolerate GLP-1 analogs? What proportion of patients are initially not able to tolerate?
So I think there's two elements. I think some patients, initially will say that they don't want an injectable, and then I think people have different ideas as to what the needle looks like, and when you show them the needles, that often reassures many of them. But some people, don't want to inject. I think, in my experience, what makes a big difference is talking to people about what will happen, and them knowing that if there's a problem, they can phone up. And I think, forewarned is forearmed. If you know the side effects, you know the sort of mitigation strategies. Sometimes you can pause the dose before increasing it, or you can drop down a bit. And I think all these things will help a proportion of people. There will still be people that don't tolerate it, but I think those strategies, will result in a much greater proportion continuing those treatments.
Great, thank you. Manal, I'll pass the baton to you to discuss the PPAR agonists and their role, particularly if insulin resistance is really a critical pathway for disease progression.
Now, this is a very interesting compound that has been in development now for a while. And the pan-PPAR agonists really address metabolic drivers in very unique ways. And lanifibranor is an actually equally balanced PPAR alpha, PPAR delta, and a PPAR gamma. In comparison to pioglitazone, which we've had for many, many years, that's an isolated PPAR gamma agent. So with a PPAR alpha, which is comparable to like fenofibrate, for example, as a PPAR alpha compound, you have the opportunity to get lipid lowering, particularly with triglycerides. It also increases the HDL cholesterol, and with PPAR gamma, also getting that glycemic control improves diabetes, improves insulin sensitivity, decreases even fasting insulin. And so the opportunity to utilize an equally balanced PPAR agonist allows us targeting against dyslipidemia, improvement in insulin sensitivity, improvement even in beta cell function of the liver, of the pancreas. And the downstream effects of that on the liver, what we've seen in the phase 2 trial is a decrease in hepatic steatosis, a decrease in necroinflammation, leading to NASH resolution. And this probably happens both with a liver-directed effect as well as a peripheral effect. So we get almost the best of both worlds, because peripherally, these agents also affect, the adipocyte by increasing insulin-mediated free fatty acid export, and also have an effect on peripheral muscle by decreasing insulin-stimulated glucose disposal. So we have a target that can work both peripherally and intrahepatically, because the PPAR-gamma agonist effect also has an effect on hepatic stellate cells and fibrogenesis. So here it's kind of laid out in what I've talked about. With the PPAR agonist, we get an anti-metabolic effect, we have an anti-steatotic effect, we have the opportunity through downregulation of NF-κB dependent gene activation to decrease intrahepatic inflammation, decrease hepatocyte ballooning, and with the PPAR delta gamma moiety, also decreasing hepatic stellate cell proliferation and activation, thereby decreasing the deposition of collagen in the liver. And there's interesting data in animal models that suggests that the PPAR gamma delta actually can potentially decrease portal pressure in the context of cirrhosis in animal models. So time will tell if this unfolds in humans. Just as a comparison between saraglapar and lanifibranor, you could see here, sarglinazone and lanifibranor, you could see here the alpha, gamma, and delta effect. They are different. So not all PPARs are created equally, is the important message. So as here you could see that pioglitazone has been studied, really actually in both patients with diabetes and patients without diabetes. In the PIVENS trial was the leading study, landmark study by the NASH Clinical Research Network, and that demonstrated an improvement in MASH activity defined histologically, and also phase 4 trial design that evaluated adult patients with NASH, looking at a 2-point reduction in the NAS score without worsening of fibrosis had an effect. Sarglitazar was evaluated in a phase 2 trial, the evidence study, also in adults, and demonstrated predominantly an increase in a decrease in liver biochemistry. And lanifibranor was studied in the NATIVE study, 2B study, again in adult patients, and has demonstrated a decrease in the SAF score. Now, the SAF score is a scoring system, unlike the NAS score, which really is a little bit more heavily weighted towards inflammatory score. So there's an enrichment of necroinflammation using that score, but that study endpoint required at least 2-point reduction in the SAF score without worsening of fibrosis. So on to a question. What is the primary endpoint achieved in a phase 2 trial of lanifibranor for the treatment of MASH with moderate to advanced fibrosis? Let you take your polling time there. All right, wow, very equally split. That's correct. So we'll talk a little bit more about this. So here we have the results of the NATIVE-2 study. The NATIVE-2 study enrolled 247 patients with biopsy-proven MASH enriched for necroinflammation, and really studied 2 doses of lanifibranor, 800 milligrams a day versus 1,200 milligrams a day versus placebo. Now, what's really important to pay attention to is the trial design here. This was a 24-week study, which is really a relatively short interval of time when evaluating a histologic endpoint. Patients were randomized 1:1:1 with a biopsy at the beginning of the study and a biopsy at the end of the study, with the primary endpoints being a 2-point reduction in the SAF score with no worsening of fibrosis, and the secondary endpoint being MASH resolution and fibrosis regression. And this really was quite striking because this was the first agent and compound to reach the dual surrogate endpoint within 24 weeks. So here you could see that there was statistically significant reduction in the 2-point SAF activity score, a 1-stage improvement in fibrosis without worsening of MASH, and also MASH resolution without worsening of fibrosis. And again, when you take a look at the placebo corrected response rates, at least for MASH resolution, we're talking about almost 27%. So the adverse and safety profile of lanifibranor was really actually balanced for adverse events across the treatment groups when it came to serious adverse events. But the most frequent side effect of lanifibranor was a little bit of GI intolerance, diarrhea, for example, but what was also noted is a very mild and modest weight gain. Now, this is a class effect because we see very modest weight gain with PPAR gamma. It also was observed in the PIVEN study with pioglitazone. But what was observed was a significant reduction in hemoglobin A1C by at least 0.5%, which is clinically significant for patients with diabetes, a reduction in triglycerides, an increase in HDL cholesterol, and an improvement in liver biochemistry, and a reduction in the CAP score, which evaluates steatosis by FibroScan. So, and there was also an improved markers of inflammation, such as the CRP, the MAC3, TIMP1, compared to placebo. So for discussion, how are the PAN agonists more likely to be used as treatment? What do you guys think?
Yeah, I think, particularly as you showed the data, we know that patients with type 2 diabetes are pretty high risk. Insulin resistance is important. So this could potentially be a therapy you could consider anybody who we think has significant insulin resistance burden as a pathophysiologic mechanism. Again, we discussed about oral therapies. So, I have some patients, about 10-15%, were not able to tolerate GLP-1 analogs because of GI side effects. Potentially that's another mix where those patients might be interested, in such a therapy.
So the phase 2 study I shared with you, the phase 3 study, the NATiV3 study is fully enrolled, and hopefully we'll anticipate further information come second half of 2026.
And now moving on to FGF21 analogs. If you look at FGF21 analogs, there are really pleiotropic hormones. They have impact on the brain, impacting food choices that we may have, impact on the liver in terms of lipotoxicity, increasing or activating PPAR alpha, on kidney, potentially improving inflammation, oxidative stress, changes in gut microbiota and bile acid metabolism, leading to improvement in gut inflammation, and potential cardiac remodeling, changes in the pancreas by potentially increasing beta cell function, adipose tissue remodeling with improved peripheral insulin sensitivity, increased adiponectin secretion, which is a linked mechanism, and also a readout for pharmacodynamic response, and then improvement in muscle sensitivity as well. These are some of the FGF21 analogs that have been tried. We will discuss data on efruxifermin, pegozafermin. Both of these are in phase 3. Efimosfermin, we have now data on phase 2b that was recently published. And then zelformin, the trial has been completed, and we'll look at data that will be coming out soon. Then we have some of the data from efruxifermin with the phase 2b on the response in cirrhosis, and then we have an ongoing phase 3 program in MASH cirrhosis with both efruxifermin and pegozafermin. This is the efruxifermin in pre-cirrhotics with MASH. Patients were randomized 1:1:1, 128 patients with MASH to 28 milligrams sub-Q efruxifermin once a week, or 50 milligrams sub-Q once a week, or placebo, had a biopsy at baseline and then week 24, and these were the parameters that were looked at. These are the results, and you can see that there was a pretty significant improvement in fibrosis if you see in these patients, both at earlier time point, which is week 24, but also continued treatment. We had greater number of patients who had improvement in fibrosis over 2 years. So this is looking promising. Based upon these data, this program has moved on to phase 3. Now we're looking at SYMMETRY, which is use of efruxifermin in patients who had biopsy-proven cirrhosis, who either had type 2 diabetes or metabolic syndrome. Again, the trial design included 181 patients with cirrhosis who were randomized to 28 milligrams sub-Q weekly or 50 milligrams sub-Q weekly or placebo, had a biopsy at baseline, week 36 biopsy, continued treatment, and then a biopsy at week 96, so 2 years of treatment. We'll look at that data. So this is 2-year data that I'm discussing here, and you can see with 2 years of treatment, we can now even reverse cirrhosis from stage 4 to stage 3. And this is 29% on the higher dose compared to 21 with a 28 milligram dose and 11% placebo. This is exciting data that now we can start reversing cirrhosis also. Based upon this has moved on to a phase 3 clinical program as well in cirrhosis. These are some of the side effects that you can see. Typically, we see GI side effects associated with efruxifermin. These are dose dependent, typically seen with the higher doses. And you can see some of the discontinuations that you could see with this particular therapy. Although potent, not all patients are able to tolerate this treatment. Now looking at pegozafermin in patients with MASH stage 2 or 3 fibrosis, where 222 patients were randomized to different doses of pegozafermin or placebo, underwent a biopsy at baseline and then repeat biopsy at week 24. And these were the endpoints that were looked at. Here are the results. If you look at fibrosis improvement to the left, you had about 20% treatment effect delta on fibrosis over 6 months. And for MASH resolution, you're looking at approximately 25 to 35% treatment effect delta in MASH resolution. Based upon these data, this program is also moved on to a phase 3 clinical development. These are some of the side effects. Typically, FGF21 analogs have GI side effects. Predominantly, diarrhea is something we see. You can have a little bit of weight loss, but it's not as significant as that we would see with GLP-1 analogs. Again, discontinuation rates are also listed here, slightly more than placebo. Now, how are FGF21 agonists most likely to be used in MASH treatment? Phil, where do you think they fit into the treatment landscape?
Sure. No, I think a couple of things stand out for me. I think the first thing is that we see that this is a condition which takes years, often decades to develop. And sometimes I think we are perhaps too earnest in terms of wanting to see early responses. And I think what you've nicely illustrated is that you see significant augmentation when you go from 24 weeks to 96 weeks. That's the first thing. But I think what you do see with these therapies is potentially that sort of added effect on fibrosis. So I think for me, clearly there's going to be, pending phase 3 trials, a role for people that are, certainly people presenting with a very advanced fibrosis in the F3, obviously F4, depending on the data. I think you could see there that for those individuals, there is a desire to stop them in their tracks and ideally have them moving back. Whereas for those individuals with earlier, more moderate degrees of fibrosis, you can take a more balanced view. So I'd probably prioritize them for individuals at that sort of late F3 going into F4 space, depending on the data.
Manal, what are your thoughts? Would you also think that they would be probably factored into more advanced disease?
Yeah, I certainly think they're going to factor into more advanced disease, but they also raise the possibility of how we're going to use this armamentarium of drugs. When could we use it as an induction therapy, for example, pulling somebody back from cirrhosis into an F2, F3, and then utilizing an alternative agent such as an oral therapy for maintenance. It'll be very interesting to see the more potent the drug, and also when associated with some symptoms of GI toxicity that patients can't, or side effects that they can't maintain long term. Can we use it for short intervals and pull patients back from severe disease, or use it even in combination to resolve disease altogether?
Definitely a lot to consider as these therapies come to clinic in future. Now we'll move on to thyroid hormone beta receptor agonists and pass the baton back to Manal.
Right, so for thyroid hormone beta receptor agonists, we have resmetirom, and resmetirom has received conditional approval by the FDA back in March of 2024. So we have nearly a year and a half now of clinical practice experience with resmetirom. Resmetirom is uniquely targeting thyroid hormone metabolism in the liver. We know that the thyroid hormone is important for maintaining energy homeostasis, metabolic homeostasis, and resmetirom acts via the thyroid hormone receptor beta, which is really strictly in the liver, thereby leaving us really with no alpha effects. And so it impacts de novo lipogenesis, cholesterol metabolism, and promotes oxidation of free fatty acids in the liver. And in earlier clinical trials, certainly resmetirom was found to lower liver fat, resolve steatohepatitis, and lower LDL cholesterol and lower triglycerides. And the resmetirom also affects probably an improved beta mitochondrial function in the liver, decreasing beta oxidant stress, thereby lending its ability to improve steatohepatitis. So resmetirom treatment is recommended for which of the following?
Number 1, VCT 10 to 15 kPa. Number 2, ELF of 11 or higher. And number 3, MRE of 5 to 7 kilopascal, or all of the above. Please vote.
Yeah, very
Excellent.
good. Yeah,
So
excellent.
looks like 26% of you picked that VCT 10 to 15 kilopascal. That's good. ELF of 11 or higher, you're getting into more advanced disease. MRE of 5 to 7 kilopascal. We specifically put in MR elastography, and that's looking at patients with cirrhosis. So I think that would not be appropriate. And then all of the above, that would not be appropriate based upon the 0.2 and 3 that I mentioned. But I think maybe it was confusing to you a little bit, so I would give you a discount, and I think those who picked 26% is good. Phil?
I just wondered, out of interest, what people's availability for these tests is. I mean, I'd imagine VCT is probably more widely available, but how many people have access to serum ELF in their clinical practice?
Not very much.
So, I mean, I guess it may be kind of a regional thing.
Yeah.
It's probably more common in and presumably MRE, presumably more common here?
Wow.
Okay.
How many have VCTE? Okay,
Yeah.
great,
Okay.
excellent.
So resmetirom treatment based on non-invasives. Now, what was really unprecedented about this drug approval pathway and the FDA's deliberation is a label that came out not requiring a liver biopsy. So we can move beyond the biopsy in considering the utilization of hopefully maybe all our new therapeutics in the landscape. But here is the proposed considerations when evaluating the role of NITs. First of all, you certainly want to have a clinical diagnosis of the presence of MASLD based on steatosis, appropriate risk factors. You've ruled out all other causes of chronic liver disease. You've assessed the presence of hepatic fibrosis and really tried to hone in on that at-risk MASH patient who has fibrosis stage 2 or 3. Now, here's what the current guidance statement is proposing. So treat those patients who have a FibroScan liver stiffness assessment between 10 to 15, MRE between 3.3 to 4.2, an ELF score for those that have the ability to order it between 9.2 and 10.4, or using combination NITs, and really paying attention to that platelet count, because a low platelet count, at least on first glance, especially if it's lower than 150, should draw some attention. If it's lower than 100, would really suggest confirmed presence probably of portal hypertension, and those are patients that require further evaluation. Considering treating those patients that may be in that gray zone for these NITs, VCTE stiffness of 15 to 19.9, for example, or the MRE and the ELF score that are detailed there, but being very, very cautious about its utilization in patients with cirrhosis, in particular patients with portal hypertension. And not to say that it's dangerous, because patients with cirrhosis have been studied. We just don't have good efficacy data as of just yet. Here's the trial design for the registrational study, the MAESTRO-NASH trial. Patients to get enrolled in the study had at least 3 metabolic risk factors, the presence of biopsy-confirmed NASH with fibrosis, predominantly 2 or 3, and at least 8% liver fat content on MRI. They were equally randomized to placebo, 80 or 100 milligrams of resmetirom with the dual endpoint of MASH resolution without worsening of fibrosis or fibrosis improvement without worsening of NASH. And the patients did undergo a serial liver biopsy both at baseline and week 52 of the study. Patients with baseline GLP-1s had to have been stable on their weight coming into this trial, but GLP-1 use was allowed. And here you could see here we have nearly a 20% placebo-corrected response rate at week 52 for MASH resolution without worsening of fibrosis, and a 12% placebo-corrected response rate for fibrosis improvement without worsening of NASH. Side effects with resmetirom that were common are really, I would say, loose stools in my clinical experience and a little bit of nausea, which happens predominantly early in treatment within the first 4 to 8 weeks and seems to dissipate and is manageable. So adverse events leading to discontinuation were really not significantly different compared to placebo, with really nausea and diarrhea being the most common early treatments.
So is resmetirom likely to be used as part of combination or sequential therapy for NASH? What are your thoughts, Phil and Manal? Phil?
Yeah, no, I'll start. I mean, we touched on this a little earlier, didn't we? I mean, I think absolutely. I think that clearly there are many patients that have started on resmetirom and are getting the response they want. I think I come back to Manal's earlier point. I think it'll be patient choice. It'll be driven by the severity of the presence of metabolic risk factors. And I think, we'll evolve. I suspect, we may probably end up in the hypertension paradigm where most people are on more than one therapy. Mm-hmm. This is a condition which, will go on for decades. Yeah. So I think that's probably where we'll end up.
Yeah, I think about this really as a liver-directed therapy. This is a liver-directed pharmacotherapy, particularly given the target with the thyroid hormone beta receptor agonism. And I think about, the incretin class really is a systemic almost therapy that targets, the metabolic drivers of disease as well as having a secondary effect on liver disease. And I certainly, the data would suggest they can be used in combination safely.
Thank you for your perspectives. Let's move on in terms of ongoing questions for MASH therapies include long-term safety and outcomes, potential mortality benefits that we will see in phase 3 and phase 4 development, use of potential combination or sequential therapy, health-related quality of life, and patient-reported outcomes. And there might be specific groups that might be interesting to look at: MET ALD, lean mass LD among lean individuals, such as lower body mass index, high cardiovascular risk, elderly, diverse populations. And I think all those would be really important as we address these issues related to MASH therapeutic landscape. Take-home points with our education program today include resmetirom and semaglutide are now both conditionally approved for treatment of MASH with moderate to advanced fibrosis, but not for cirrhosis. Several therapies are in phase 3 clinical development and are showing promise for treatment of MASH-related fibrosis, such as incretin, PPAR agonist, such as lanifibranor, FGF21 analogs, as we discussed. FGF21 analogs and other therapies are potentially showing benefits in patients with stage 4 as well. Now we are ready for Q&A, and if you have any questions, you can send it to us through web, or you can also ask here. I'll start with the questions that we've already received here. Question number 1, I think this would be, let's start with, what is the role of ELF testing to monitor the response at this new therapy? Manal, do you want to discuss that briefly?
Yeah, I got to say I have not I've utilized the ELF to stratify risk of disease. Maybe the at-risk MASH patient at a threshold of, like, say, 9.2 and cirrhosis at 11. I have not used ELF as a therapeutic, as a biomarker to predict therapeutic response. I am really looking at a reduction in liver stiffness by FibroScan at 6 and 12 months out. I'm looking at liver aminotransferases. And I don't really have access to ELF at my institution, so I have less use of it in the therapeutic landscape.
That's great. This is a question from Neil Saptarishi. Where do you see lanifibranor fitting within the evolving treatment landscape, especially in relation to resmetirom, GLP-based agents? Which patient subgroups may benefit most? For example, diabetic, stage 3, metabolically complex patients. Phil, your thoughts, and then Manal, yours.
Yeah, no, sure. I mean, again, obviously need to see what the phase 3 data will show, but I think, based on the phase 2 data, I think you're seeing, a strong early signal on inflammation and fibrosis. So I think, again, it comes down to patient choice in terms of oral versus injectable. I think somebody who's got evidence of insulin resistance, you can see the value there. And depending on the signal that we see on fibrosis in the phase 3, it could also be used for people that have got, more difficult to treat fibrosis.
No, that's really important. Manal, your thoughts on this?
Yeah, I agree fully. It's exactly how I look at it.
Yeah, one of the things that, when we looked at transcriptomic signature in patients with cirrhosis, when you're looking at cirrhosis reversal, one of the key signals that you see on mRNA is, PPAR gamma agonism. And that's a signal for inactivation of an activated hepatic stellate cell. So I think it'll be important to see, potentially how Lani would have a role in stage 3 and stage 4 fibrosis in future, particularly as an oral therapy. Because we're not concerned about, a muscle loss or any of those domains, so potentially it could be an interesting niche there as well. There's another question looking at what do you see as the role of dual or triple incretin therapies for MASH? Manal, your thoughts about dual agonists, and I think including glucagon, greater side effects, and so forth?
Yeah, I think certainly when comparing the weight loss effect of a single versus a dual, we may see added weight loss effect with tirzepatide versus semaglutide. And there is emerging data that weight changes alone in the space of MASLD and MASH may influence clinical outcomes. The triple agonists are going to be a very interesting class to watch because it really depends highly on how the constituents are balanced across, the GLP-1, GIP, and glucagon. Glucagon has the potential to increase glycemia, and certainly how much glucagon effect you have in the agent versus how little you have in the agent could also influence not only side effects, but also the effect that you have intrahepatically on fibrosis. So it'll be interesting. What are your thoughts, Phil?
Yeah, I mean, just to pick up on that one bit, I think when we think about the GLP-1 glucagon, I think it's important to realize that they're not all the same thing.
That's right.
Both the constituent molecules, but also the potential ratio. And I think you could sort of see a precision medicine approach here. So, if you have somebody who's got difficult to treat diabetes, you probably want a GLP-1 heavy combination, the glucagon giving you those potential liver-directed effects. Whereas if you have somebody who perhaps doesn't have, overtly challenging metabolic problems, but they've got liver fibrosis, and this is that sort of continuum into sort of a lean MASH spectrum, you can see a glucagon heavy combination being a more appropriate therapy.
Yeah.
And it'll also be very interesting to see when you can potentially foresee somebody who's on lanifibranor, for example, who also has diabetes, gets modest, a little weight gain or needs more anti-glycemic effect and gets a GLP-1 added. I mean, the nice thing is we're going to have an armamentarium of drugs to tailor appropriately.
Yeah, no, certainly. There's this question about what to do once patient finished treatment, if there's such thing as that. And there is a response, stop, or to continue treatment. And so, Phil, how do you think about NASH treatment? Do you thinking Do you think that it would be finite, or this would be something that will continue? And if you were to stop treatment, what would those conditions be?
There's a question. Okay, so I think that there's two dimensions to this. I think that the treatment of the causes and the metabolic drivers and inflammation, I think that's going to be a longer-term therapy. Yes. So I would say lifelong. I think you may also see a sort of a flexing into a sort of dosing up, dosing down, depending on how people are doing. And a glib analogy would be the way people use proton pump inhibitors. They might sort of modulate that. But I think that will be long-term treatment. I think we see that if you discontinue those treatments, people regain weight. I think the fibrosis story is interesting. It may be, to pick up on Manal's earlier point, that we may have some time-defined interventions there. So conceptually, you take somebody from an F4 or an F3 down to a safer place, and you might then say, okay, now we can just use another therapy. I think what's going to be difficult is defining, what that safe space looks like, and how long do you need to be confident that somebody's been treated to get there. And I think that's one of the things we're going to be working through.
Yeah, I'm a believer that we're really going to be talking about lifelong therapies. I mean, time and time again, after MASH studies, the therapeutic intervention, it doesn't matter if it's diet or exercise or any target, once it's stopped, we see a rebound of liver enzymes, we see a rebound of weight, we see rebound of glycemia. And if we step back and think of treating a patient holistically, by using these agents where we are treating their cardiometabolic risk factors as well, and of course, while liver-related outcomes become more prevalent as fibrosis increases, the primary cause of morbidity and mortality is cardiovascular. So unless we unlock the puzzle for the one metabolic driver and have a very targeted cure of metabolic syndrome, which I don't foresee happening in my lifetime, I think we're going to be talking about long-term treatments.
There's one more question here, particularly focusing on patients who may have lean MASH with fibrosis, and what sort of treatment approach you would take in that setting, Phil and Manal?
Yeah, so I think, to me, lean MASH it means different things to different people. I think there are people where there's a sort of misclassification. But even for those that are appropriately classified, I mean here in terms of body mass index and ethnicity, for those people that do have, they've got inflammatory injury, they have maybe fibrosis, but they don't have as many of the other features. I think we don't have a huge amount of data to inform what we do there, but logically, you'd be picking treatments which will target. I mean, often they have insulin resistance, but they don't have the other features. I think there you'd be looking at treatments which have an effect on fibrosis and inflammation, and perhaps some of the other therapies might be sort of, at this point in time, not as appropriate for them.
No?
No, I agree. I mean, despite being lean, these patients have increased visceral adiposity and insulin resistance, and the benefits on the liver may not all be weight dependent, benefits. We can get weight independent benefits. And this is where I could see resmetirom being used as an agent. Even lanifibranor this is an opportunity for an oral therapy when somebody doesn't want or has no significant need to lose a lot of weight. But even then, and Phil can speak to this, there are patients in the ESSENCE study that were lean MASH that still had a benefit even from GLP-1. So I think an anti-metabolic approach, because leanness does not infer the absence of metabolic stress.
Yeah.
Now we talked about lean MASH and related fibrosis. Let's talk about patient with obesity and mast cell with fibrosis who's already on semaglutide for obesity for a year. Comes in, you evaluate, and has a liver stiffness of 10 kilopascal. And so would you consider adding resmetirom or continue semaglutide? You don't know what their liver stiffness was a year ago when the obesity medicine specialist started their treatment. So please walk me through as what you would do in this setting. Manal and then Phil.
I think I'd want to know first and foremost if they have dose escalated their GLP-1 to a maximum dose that we studied and saw as beneficial, 2.4 milligrams once a week. You know, the very low doses of semaglutide may not have the ideal optimal liver-directed effect. So if they're on 0.25 or 0.5 or even 1, I would try and work with them to increase that dose.
Great point.
If they're already at an optimal dose of semaglutide or a dose, maximum tolerated dose, let's put it that way, then I would consider adding resmetirom.
Okay. Phil, your thoughts?
Yes, I think my approach to this would be, you know, sort of based on where I think the person is at the moment. And I think if they're coming in at 10 kilopascals, I would take the view that, you know, there isn't necessarily a crashing urgency to get on with it. So I think I would want to understand as much as possible what's been their trajectory in terms of liver enzymes, in terms of weight change. You know, if nothing's moving and they're up titrated, then obviously you need to look at a different therapeutic approach. But if, for example, they've lost some weight, the liver enzymes are coming down, you know, I think you would have a conversation where you could say, listen, this is a condition that takes a while to turn around. You know, it could treat for another year before. I think whilst we will undeniably have combination treatments, I think we should be at least measured about how quickly we get there with patients. I mean, if somebody's got a FibroScan of, say, 15, 16, then I would put them in a different risk group, and therefore there's a greater urgency in terms of escalating treatment.
Yeah, and sometimes we, you know, I think we're so quick to try and see a treatment response, right? You know, the sooner the better. But you know, the natural history of this disease takes years, if not decades, and some slow and steady may win the race, right?
Well, I think the other thing that we've not talked about is, you know, if somebody's readouts of fibrosis do not change, if they're in that sort of F2, F3 category, then they're not going to get a liver decompensation event from there.
Right.
Yeah.
So, you know, you know, we sort of wrestled with this the other day about we want to improve things, but them not progressing to cirrhosis in itself will stop them getting liver outcomes.
So the absence of progression, in fact, is a treatment outcome that we
Yes.
should be happy with.
In clinical practice, certainly.
Yeah.
Yeah, yes.
Yeah. As you can see, you know, we are friends. We can talk for hours. We could be sitting here till tomorrow morning. So please let us know when the time is over. But also, if there's a burning question here from the audience, I'm happy to take that as well. Next question I'm going to take is there a role for milk thistle with NASH? Manal.
Is there a role for milk thistle? Yeah.
Short answer.
Only to the pocketbook, maybe. We don't have any good randomized placebo-controlled trials showing efficacy on liver disease.
Phil.
No.
Excellent. Thank you. Let's see. Which treatment class shows the most promise for MASH patients with cirrhosis? Manal.
My eyes are on the FGF21 class.
Okay. Phil.
Well, I think you obviously presented the data on FGF21, so obviously that's really encouraging and, you know, great for the field, great for people. I guess in terms of other therapies which have looked at that, I mean, we see resmetirom has efficacy, albeit the stuff we've seen so far is open label as opposed to against placebo control. So I think both of them are encouraging, and I think the take-home message here is that this is a condition which will take time. You know, we know that if you treat people with hepatitis B and cirrhosis, okay, with drugs which are clearly not antifibrotic, you get a reversal of that cirrhosis in 80%. It takes 5 years. So I think, you know, come back to an earlier point, sometimes it's just not trying to rush things too much.
I agree. I think if you think about even lanifibranor data, we have good data in patients with stage 2 and stage 3 fibrosis, although we don't have data in cirrhotics, but it'll be important to see, you know, what happens.
Sure.
Manal, has there been any analysis in the phase 2b program, similar to some of the analyses we've seen with other programs where if you had some patients who were classified at stage 3, but then on reassessment really looked like stage 4, if they had any response. Have you or anyone looked at that in the lanifibranor phase 2b data set?
Well, I think the sample size
Yes.
just was too small to infer those type of sub-analyses. Should it have occurred, it certainly didn't resonate in any safety signal. But given a phase 2b study, when you start performing sub-analyses on smaller cohorts of patients, it would be harder to infer any conclusion.
And I think we need to be a little bit careful with those, because those patients are probably, by definition, going to be at the milder end of the cirrhosis spectrum, as opposed to your conventional cirrhosis studies. And I think this is one of the challenges. You can go from having, albeit compensated, very advanced cirrhosis to still having cirrhosis. That's an improvement, but it might not be captured by a categorical change. So we just need to recognize the kind of complexities in terms of how we look at response in that setting.
What we do know is it was as effective in the fibrosis stage 2 as it was in the fibrosis stage 3. So there wasn't any, change.
Well, I want to thank both of you for such an exciting program and a great discussion about all therapies related to steatohepatitis. And I also want to thank all of you for being here with us for all the Q&A, and happy to take any questions if there are later on as well. So with that, I think there was a QR code before this that you can access this program and do the post survey as well. To earn your credit, if you can scan this, you would be able to earn a CME, a CNE, or a CPE credit. And this was valid through 12/7/2025. With that, thank you so much for joining us for this Medscape Educational Life.